Good afternoon. My name is Fred Phelps, and I'm the Executive Director of the Canadian Association of Social Workers. Today, I have the honor of welcoming you and the audience to the first of 3 webinars in a series on client-centered mental health and addiction systems that is being presented today in collaboration with the Nova Scotia College of Social Work and the Canadian Association of Social Workers. Today, we have over 500 social workers registered for the webinar, and we are honored to have Todd Leader, a registered psychologist, and more importantly, a registered social worker who has spent the last 26 years leading service development and transformation, as well as health promotion, particularly in the areas of mental health, addictions, and primary care, to present to us all today. In terms of process, for those on the line of this webinar, the first half of the webinar, approximately 30 minutes, will be a presentation by Todd, followed by a half-hour question and answer period that I will moderate. During the presentation, you'll see there is a place that you pop your questions in. Type your questions in at any time, and I will begin to ask them at the end of Todd's presentation. Please note that a recording of this webcast and the presentation itself will be posted on the CSW website shortly after the presentation, probably within the week. So now, without any further wait, it is my distinct pleasure and honor to welcome Todd Leader. Todd?
Hi, folks. Glad to have you here today. I see that we've got a fair number of people, and that's quite exciting. So what we're going to be talking about is the idea of creating what I refer to as a client-centered system in mental health and addictions. But what you will find as we talk through some of this is that the concepts that I'm talking about actually will apply quite well to other public sector systems. So if some of you are working in child protection or income assistance or other types of government programs, you will find the concepts will make some sense. It's just that the examples will apply to the mental health and addiction system because that's the system from which I developed these thoughts. And so we're going to talk at some theoretical kind of level, but mostly at a very pragmatic level about how we actually get to the point of developing a client-centered system and what that means. So we start off with, when people think of client-centered, that term itself really originated with Rogers and some others really thinking about therapeutic interventions and Carl Rogers' approach to client-centered therapy. We've generalized that across many fields and many professions, and we've generalized it to be thinking about client-centered care and client-centered treatment. We put other words after that term. And so across all professions, what we see is care providers within virtually every type of program, every type of social or human service, who will refer to what they provide to patients or clients, refer to it as client-centered. I have no doubt about that part. So just to be very clear, that is in no way the focus of what I'm talking about today. I'm not at all implying that the psychologists and social workers and nurses and doctors in any of our systems, but certainly mental health and addictions, are not providing what we would consider to be client-centered care, which, summing that up really would mean providing care that is empathic and compassionate and responsive to the patient's needs or the client's needs. So I don't doubt that part is happening, but let's just talk a little further about it and you'll see the distinction that I'm going to be making. So first we have to understand the term itself in its general sense. So for us to say something is client-centered really means that the client is the priority. All right, so if we say the client is the priority, that should mean something specific. And if we were to look across the country, what we will find, look at your own health authorities, your own health departments, look at your social service or community service departments, you will find terms like client-centered, patient-centered, people-centered. You'll find them plastered on every plaque. You'll find them, they're parts of their mission statements or their statements of values or priorities. It is very common for all of our organizations to actually state that the client is the priority by using this phrase, client-centered. But what does it truly mean for something to be the priority? This is where we have to get really careful and precise to make sure we're not misusing a term or misleading the people who are our clients. And So here's what it means, really. The root of the word of priority is prior, which means if we're saying that our system is client-centered, we're saying that the client comes prior to other things. We misuse the word priority all the time. We use it as if it means important, and it doesn't. It actually technically means more important than. It's a term of relativity. It's not a term of an absolute kind of term. So for you to say, oh, these three things are our priorities, is actually a misuse of the term unless you're going to rank them. What is number one? Which one of those things comes prior to the other things? Because when it comes down to the reality of things, you can't always achieve everything you want as a practitioner, as a manager or director of a system, as an organization. You can't do it all. And so you do have to have a predetermined understanding of what will come prior to what. Because otherwise you're making a statement like client-centered in a really hollow kind of way. It's meant to look good, but in fact does not guide the administrative decision-making unless you're ready to say, this is number one, this is number two, and if we're ever stuck having to choose between them, we will choose the one that we've in advance said is number one. So client-centered means the client actually is number one when we're faced with a choice, comes prior to other things. Sorry. So, so as I've said, most of the people who are actually caring for individuals out there, they're providing client-centered care, and most of them will actually say that. Many of the kinds of satisfaction surveys that organizations do with clients, much of the public kind of, even during public outcry about systems like mental health and addictions, you'll still hear people actually complimenting someone who provided care for them and talking about how compassionate that person was. That's not actually where the problem is. That's not what people are complaining about across Canada, because people feel like they get good care once they're in care. But the problem really is that the hoops that we make people jump through on the way to getting that care, that's what people are complaining about. They don't feel like the system is actually about them. And so what I mean by that is they're not saying the care is not about them. They're saying the processes that they go through. And so we'll look at some examples of this. But the processes, from the time someone decides, I need help for my substance use, for my feelings of sadness that seem to be lasting too long, for these things that feel like voices in my head, or this anxiety that's starting to become troublesome. When someone starts to realize that, from that moment on, they make a decision to interact with our system. And so they might decide, okay, they're going to phone to try to get an appointment. Well, in some areas, they might, when they do their Google search, they might find multiple phone numbers because there are multiple clinics around a particular city or around a particular community or province. And so you've got somebody who is emotionally or potentially cognitively impaired in some way and sort of suffering from symptoms that make them become overwhelmed with decisions that are complicated or unsure of themselves or confused. And what they get is a list of numbers, and they have to try to figure out which phone number to call. Well, that shouldn't be, because if the phone system was actually designed to be client-centered, then it would be a single phone number, and we'd figure out the rest. We would make it so that no matter where somebody called, basically, they would get directed to the right place by us, and not given a second phone number. Because if I've got an anxiety disorder and you're going to make me make a second cold phone call to a stranger, then we're going to have I'm going to have a bigger problem than I had. So, this part of it isn't always easy, because from one area to another, you may have multiple numbers. One case, you might have an 800 number that's really simple, and somebody answers the phone and tells you what, and connects you to the right people. That would be client-centered. But when somebody answers the phone, the other part of it is, sometimes we'll find that we have automated systems. We love menu trees, right? So put up your hand if you love getting a voice answering and saying, press 1 for this, 2 for this, 3 for this. Well, if you're doing fine, then you might not mind that. If you're trying to make an appointment for an orthopedics clinic or a day surgery or something like that, that might not be that bad. But I'm going to tell you, as somebody who has lived with depression, I can tell you right off the bat that getting an automated voice, if I'm feeling depressed, that actually says I'm not important enough to this program for a real person to answer. That's the way it would feel. And if I've got an anxiety problem, then I have to try to listen to those cues closely enough to try to anticipate which of those means what I think I'm looking for. And the language and the jargon in those cues might not actually fit anything I understand. And so again, not having the phone answered by a real person, and in fact, let me go a step further, a real person who cares, because we all know when we're talking to somebody who cares versus somebody who's just doing their job. There is a difference, when someone answers the phone who might be the best data entry clerk in the world and got the job of a receptionist because they're going to be doing all that kind of data entry perhaps, but really isn't warm and friendly. We know the difference. We feel the difference. And again, if you have somebody dealing with anxiety or depression, that's a real problem because I don't even feel welcome. I don't feel visible or important, even with the person that's supposed to care. And the intake process. So we move on to the intake process. Well, that's the process where we technically take someone into a service. We accept them as a client, and across the country you'll find a variety of methods in place. And there are older methods that have involved, for instance, taking down all the information, doing this almost like practically a brief version of a full assessment over the phone, or sending an assessment document home for somebody to fill out and send it back in, and then clinical staff sit around and determine who's going to take that case and who's not. That's an old method that I think is finding its way out of the system, but we still end up with people being sort of having information gathered from them, and then they'll be told that somebody will be back to them to book an appointment. We still have that happening. Well, if I have anxiety, if I have any kind of illness that is causing it to be difficult for me to have made this call, I don't want to have a second conversation. I'm calling you for an appointment. Therefore, what I really need on the phone right now when I'm with you is an appointment. So we need to set up systems. If they were really about the client, then they would be designed to give the client what he needs when he calls. And if I'm calling right now because my addiction is becoming a problem, and I've finally gotten the impulse to make that call, then the intake process should actually give me what I've called for while I'm on the phone. Because if you try to call me back, first of all, you may not get me. If I'm living a bit of a transient life due to my addiction, for instance, which is pretty common, or even my mental illness, or by the time you call back, my motivation to even engage in this process may be gone. So, data collection. I can say this with certainty, and if there's anybody that disagrees, I'll apologize. But there's no social worker in the world that believes that we don't do enough paperwork and we don't make our clients do enough paperwork. That simply doesn't exist. And all of that is really about data collection for the sake of the record, and it's about covering the organization in terms of liability. Those are designed around meeting the needs of the system, not the needs of the client. There has never been a client who has ever said, "Do you have any more paperwork for me to do?" That's just not happened. Clients in any of our social systems, they're paperworked to death. They're questioned to death. And most of that is not based on any of their needs. So our systems should be looking to minimize that. And I'm not saying eliminate. That's ridiculous. But minimize it. Ask the question, are we really, is it possible that throughout all of the steps we put people through, is it possible that they're answering the same question more than once? If so, figure that out and get rid of it. If there are forms we don't need because they've just been around for a long time and they were put in place for a certain reason years ago, get rid of them. If they're not meeting an actual need right now legally, and if they're not meeting a client need, then we should be trying to eliminate those forms, that paperwork, the questioning that we do, and along with that, and I'm going to say clearly, along with that, get rid of a lot of the paperwork that the social workers and the other clinicians actually have to do, because, as you all know very well, Every hour that you spend doing documentation or administrative work is an hour that is being taken away from a client, taken away from maybe a family in child protection, taken away from a client in a mental health and addiction program. We need to start to focus on that as a priority, because that is not a client-centered system if we're using clinical time to do non-clinical things that are unnecessary, and we're just rationalizing them as necessary. Wait times. We've got to think about this issue of wait times. How do we get at that? Well, if we look across the country, what is the number one concern the public has? It is that. We can't get in. We can't get into the system. We end up waiting for weeks, months, in some cases more than a year. And that really comes down to how we design much of the system inside. So, for instance, it comes down to things like how much of the clinician's time is being spent doing things that are not clinical, or that are not their expertise, or that are things that they have not gotten into this work to do. Because every bit of that administrative time, whether it's sitting in meetings that are the manager doing an hour-long FYI, updating everybody on everything because the manager might feel the need to share all that information with everybody, well, send it in an email and people can find ways to get that. But taking clinical time that could be another appointment makes a difference. So if you've got a staff of, let's say you've got 20 clinicians in a clinic, and they're spending 2 hours every Monday in a meeting, and an hour of that is clinical, consultations, that kind of thing, and an hour of it is more administrative, information, those types of things. Cut that 1 hour of administrative time off the meeting. You now have 20 hours or 20 appointments per week. That's 80 appointments per month. Your wait time just dropped with one slick little decision. So, making hard decisions about how do we use the time of the people that are in our programs and for the purposes that they were hired, that really matters. Waiting rooms are a funny one for me. We have waiting rooms. We're all used to waiting in all health services, for sure. It's normal for us. That's why we have waiting rooms. It's why we call them waiting rooms, because we plan for you to wait. That's what they're for. And so otherwise we'd call them hallways, and people would just walk through them. But it's a place where we intend that you're going to sit for a while. And so is that client-centered? Well, it's not. So one of the simple things that can be done really is simply make it a rule, make it a policy that if a client shows up on time, the client gets seen on time. We have an agreement. We have a contract. The agreement that a client makes when an appointment is booked is, if I show up at 1 o'clock, you will see me at 1 o'clock. It's a two-way agreement, not a one-way commitment. And so that system piece, we've been failing to meet our end of that bargain. And so we don't have a client-centered system from that perspective. So one of the things that I did with the program that I was leading was, it was the most authoritarian thing I've ever done, actually. I think I just said, from this day on, if a client shows up on time, the client gets seen on time. And you know why? Well, because the client is the priority, number one. And so the paperwork that you're doing the case notes from the previous client, you're in a meeting with your boss, you're on the phone with somebody, doesn't matter. The question, it's not to say that those things aren't important, but where do they sit when we number them in a list of priorities? Well, if we say it's client-centered, then the client that just showed up is number one. And so drop everything else and take the client in on time. The only exception that I allowed at that time was if you're still with the previous client and that client is in crisis. Clearly, that's a switch of priorities at that time. But otherwise, just make it happen, because everything else is number 2 or 3 or 4 on the list. When I made that decision and we implemented that, within a week or two, our waiting room actually became more like a hallway. And people would be sitting there, but if you watched, nobody would be sitting there for more than, I'm going to say, maybe 3 to 4 minutes maximum. And that might be because they showed up a couple minutes early. We've got a long history in mental health and addictions of wanting to assess everything to death. So a first appointment in either of those program areas, a first appointment could take anywhere from 1 to 3 hours. When we go through, might be 10 or 20 pages of structured interview questions, assessing all of their mental and emotional and psychological issues and their substance use. Well, that's really the equivalent of I break my leg, I go to the emergency department, and all of a sudden in the next couple hours they're doing a full body MRI, they're doing a CAT scan, they're running blood work, they're checking everything else about me, an EEG, an EKG, because they want to assess for everything that might be wrong with me. Well, I can tell you what I'm here for, and you can see it. It's this leg right here. It hurts. It's broken. Please just fix that. I didn't ask you to look for other things. We'd get pretty pissed if we took our car into the garage to get one thing done and they checked for a whole pile of other stuff, and they do that sometimes, but we don't really like that because we didn't ask them to do that. But we somehow assume that people coming for help with mental health and addictions don't have the competence to be able to identify the thing that they want to work on, and that we really need, as experts, as a system, to be able to look and see what really is wrong with them, when in fact we should just be listening to people. And I'm not saying that there aren't people whose level of competence is beyond that point, but that will become evident. But having it as a standard for all of our clients, that's problematic because it's not about the client. The client comes in and says, I'm feeling depressed. How about if we just believe that and we start talking about how to deal with that, and we start assessing and treating that? And if during the conversation somebody starts to speak in a way that sounds delusional, well, then you might explore that because it's on an as-required basis. But you don't need to assess for everything. The person's here for help with what they have identified as depression-related symptoms. So let's just do that because it's what the client actually wants or needs. So those are just some examples of what I mean by system pieces not being client-centered. And you'll note that none of those have anything to do with any of you or any clinicians not doing really good work. They're not related at all to the concept of client-centered care. They're related to client-centered systems. And one of the real problems is that administrators in our systems historically have not been encouraged to think of their administrative decisions as needing to be client-centered. The concept of client-centeredness is so tightly attached to patient care that it's never seen as being part of administration. So, if you look at what's happening here, we've got other concerns like data collection, like legal liability, like efficiency of our phone systems, like getting the meeting over with before we see the next client. We've got all kinds of these other things that actually are coming prior to the needs of the client. So the system itself cannot be claiming to be client-centered if those types of system activities are clearly having the client be number two behind things like finance, politics, liability, efficiency for the system, for the staff, perhaps union concerns, perhaps management convenience, scheduling convenience, all of those things. If they're coming prior to what the client needs, then it's system-centric. It's not client-centric. So the question is, who's to blame? Whose fault is it? Who actually caused this? Who is it that's doing it? Does it mean we have a whole pile of managers and directors and VPs and CEOs who themselves don't understand client-centeredness or who don't, in their hearts, put the client first? Absolutely not. I'm not saying that there aren't some out there, but that's not what the issue is, because when somebody gets hired into a management job, what ends up happening is that they assimilate to a job that has evolved over decades and decades. These programs have never been designed. For the most part, they've never been designed. The systems have never been designed. The clinical programs, the clinical interventions have been, but the systems haven't been. They've been tweaked. They've evolved over generations. So you hire a new manager, well, somebody, a director or somebody, actually coaches that new manager on what the job is and how it's expected to be done. So that new manager assimilates to the way the system actually works now and the way decisions get made. It's not that new manager sits down and says, okay, how do we do things that are best for us? He or she just assimilates to the role and then moves on to a director role and then, and so on. It's an evolutionary problem and an assimilation problem that nobody stepped back from it and said, well, what if we were to sit down with a whiteboard and start to say, how could we design this? instead of just accepting the way it is and tweaking it with tiny changes here and there that end up looking, in a public sector system, end up looking like major changes. Once you glossy them up and put them out in a news release, they look like major changes, but really very few of them have direct impact. The clinical changes make an impact, but the system kinds of tweaks that get done are usually so small that they have very little impact on the public and on the client's experience. And that's why public dissatisfaction has not really changed regardless of this sort of ongoing evolution or tweaking of our systems. And so that's where the problem lies. We need to step back and say and ask ourselves the hard questions, really, about how do we intentionally design client-centeredness at that administrative level and in those processes. How do we intentionally design that? And stop thinking about just the clinical part. We've got competent people doing that. But what kind of crap are we putting people through on the way through to get there? On the way in and out is like a maze for people that just slows them down, confuses them, stresses them, and in some cases even causes harm. If I go back, I'll just give you another example. If I go back to the waiting room, what if I have an anxiety disorder that happens to be social anxiety, and you have a waiting room and you typically don't see people on time. The system isn't set up to be firm about that one, and I show up and I'm waiting for 15 minutes and I've got social anxiety and the system is making me sit in a public room with strangers. Oh my God, that is an ethical issue, an organizational ethics issue, because it arguably is causing harm to the exact disorder that I'm here to receive treatment for. I use the analogy of that being the same as somebody going to a knee replacement clinic that is on the third floor of a building with no elevator. The process of getting to the service to fix the knees will actually cause harm to the exact same part that's supposed to be fixed. And we need to step back and really ask ourselves, how do we move forward to create the system part so that it's truly client-centered? So the two things I'm going to say that you shouldn't do as the answer to that question. One, don't start off with generally asking questions among your team, how do we make this client-centered? It's too vague. It doesn't get you to the true heart of what client-centeredness is about. Now, in social work, that the concept of empathy, the concept of trying to understand the world through somebody else's eyes is vital to being effective with people. So we have to start to use our imagination, not our theoretical knowledge about client-centeredness. But what I'm going to say is don't put yourself in that situation. Don't imagine what it would be like if you were the client. Because if somebody said that to me, well, Todd, what's an acceptable wait time if you were the client? I'm a patient guy. I might say, I could probably handle 2 months, maybe 3, but more than that, no. But if you said to me, instead of that, if you were to say, well, Todd, what would be an acceptable wait time if this was your daughter who was the client? Well, I'm going to tell you, my answer is going to be open the door because I'm driving in. I'm not waiting. I'm not going to tolerate 2 or 3 months. If this is my spouse, my father, my mother, my son, someone that I love, my tolerance changes. And so if I want to really know what would a client-centered system look like for any part of that, the phone system, the intake, the waiting room, and there are many others in my book, many other examples of these kinds of system issues. I've just picked a few to highlight in this webinar. But the bottom line is the way to answer this question is to put in place of the client a specific person that you care about in your life. And when you do that, you end up with answers coming that are very, very real. Suddenly you understand what this client-centered system piece is about. You step away from the client-centered treatment part and the client-centered care because that part is there in most cases. But it's suddenly easy to understand where the flaws actually are from the administrative side of things, from the bureaucratic side of things, from a political, financial, legal perspective. All the ways those things get in the way suddenly become very, very clear if you imagine yourself holding the hand of your spouse or your child to try to navigate through the system. So keep that as your key question, because that question, the answer to that question, I believe the answer to that question is the true definition of client-centeredness in a system. And 30 minutes on the mark, and we're going to start with questions and answers, and Fred is going to be facilitating this part. And so I'll just move on to the last slide to leave it up there for you while we're talking. And Fred, I'll hand it over to you.
Well, thank you very much, Todd. As Todd has said, we're going to move to question and answer. So if you have, there's a number of people who have already typed in their questions. And so if you have any, please do type in. And the way it works is I'll try to get to all your questions. And we have about a half hour set aside right now to answer questions. And I'll lump them together if they're ones that are similar. It's kind of a mind shift, Todd. I appreciate the presentation. I'm listening just like every other audience member, and things are going through my mind. And I think for myself, my first question, I think, comes from that intentional design. I like that thought about an intentional design. And you may get into it in your next webinar series, but is there a system? I know the UK and the Australia have taken a more systematic approach to mental health service gaps in the last few years. Is there a community-based system in Canada that you've seen? Is there an example of something that has moved and from its design of being more of a system-centric to an intentional design around a client-centered?
Well, what I'd say, Fred, is that if we go across the country, we're going to find lots of pockets of some of this. And I don't think anybody's gotten it perfect, because I don't think there's such a thing. And I'm going to go back to, though, the part of your question is about kind of, is there a model? You know, has somebody actually kind of gotten this down pat so that there's a model we could potentially apply? And I tend to believe, actually, that the idea of adopting a model actually prevents us from becoming client-centered in the way that I'm describing, because it dictates a bit of a standardization. Like, this is the way we're going to do it. This is the way it will fit with all clients. And standardization is the enemy of client-centeredness. It by design, a standardized model is inflexible. It doesn't allow for responsiveness from one community to another, where we know there are cultural differences. Even within the little province of Nova Scotia, you go from one community to another, you will find cultural differences and different needs that the program should be offering to the population. But then you need to be able to be responsive to individual client needs as they come in, and actually, in some ways, do things differently to whatever extent is possible to meet the needs of individuals. So, you know, I'm not aware of any system that has achieved perfection, and I wouldn't want to see one deemed as that. I think of this as being a process of asking the right questions and continually asking that same question about client-centeredness at every decision point, so that it's an ongoing process of rebuilding and then continuing to change it. And so I believe the status quo, we should never be accepting it unless it's perfect. And given that it's never perfect, I'm proposing more of a process for ongoing change once you do the transformation.
Thank you. Thank you very much. I'm just going to head right into questions, because we have quite a few here. So this one is a long question, so bear with me. What's your recommendation for the most client-centered intake and assessment process? The person says, we've been running an exciting pilot here at our Women's and Family Center, where we're offering our clients wanting to access our services for addiction options. They can either complete paperwork and be seen the same day, come in another day, or walk in an appointment, or receive a set of appointment for a later date. It seems real client-centered is about giving them the choice, and for women, it seems they prefer choice more than an immediate treatment, as they get used to what they might be attempting to change. Long question. I hope you followed that.
I got to say, I love that. I think that philosophically, that's brilliant, because I think that point about valuing the choice, that really matters a lot. And that's one of the things that I found fascinating in terms of what we offer and how much choice we offer. Because when we were transforming the program that I was running at one point, I remember us talking about opening for evening hours to provide those options to people so they had choices. For people with low-wage jobs where they didn't have such a thing as sick days and all the benefits that many of us have had in our work life, they end up having to lose income that they're using to feed their children in order to come to a daytime appointment. So I started suggesting evening appointments, and so we started planning them, and one of the staff said, well, that's not going to work. Nobody's going to come for those appointments because they've never asked for them. So that's the evidence that they don't want them. And all I could think at the time was, well, I don't go to Walmart and ask them if I can buy a Toyota Corolla either. Because it's not because I don't want a Toyota Corolla. It's because I know Walmart doesn't offer them. So I'm not going to ask a 9-to-5 program for an evening appointment when I know they don't have them. But providing that choice made an incredible difference for the clients. And so giving them choices of time as well for a drop-in, walk-in kind of opportunities, plus choices of what days of the week and what times, instead of sending them an appointment, like many services do. I love that. It's brilliant.
This one's first a comment, and then I'll move to a question that follows it. Many decisions affecting frontline services are made at the provincial government level, cuts, for example. I do, however, agree that there's much we can do in the front line to improve comfort for our clients. Even the smallest changes can make a difference. And then the next question, it comes from Justin. How do you deal with resistance to change from leadership? And I'm assuming from management.
Yeah. Well, that is a tough one, and I had the fortune of having good leaders above me when I was doing this transformation. But the secret to resistance to change above you, in terms of the leadership, and that's where this actually lies. Everything I'm talking about here really lies at that level. It's at the leadership decision making, and the secret to that is to make them realize that this will give them the answer to their own mandate. And because there is no place in this country that has a completely satisfied public when it comes to mental health and addictions. It just doesn't exist. And it is the managers, the directors, the CEOs, it is their accountability, in fact. It's not yours as a clinician. It's their accountability to satisfy that public and to make them feel like the system is designed around their needs. And to cut through the bureaucratic stuff that the public hates. So I think I'm reframing it in terms of client satisfaction and public satisfaction, because that is, in fact, what happens. I mean, in the area where we did this transformation, we went from being a normal area that had negative media coverage about all kinds of mental health and addiction issues, same as everywhere else, to a 3-year span with nothing but positive news items in that geographic area. Nothing but positive, including national television coverage. The public satisfaction is one of the outcomes of this that administrators and politicians should be able to understand. We just have to let them see that this is part of that answer.
Thank you very much, Todd. A statement first, and then a question. Then the statement comes from, and I'm sorry if I mispronounce your name, Louise. She says, First Nations communities have been doing this for a long time. People first, families first, and paperwork later. I like that comment. And so there comes this question from Sheena. What is the idea balance or ratio of direct care versus indirect? I work with providers who are concerned about too much direct burnout. Where's the sweet spot?
Well, there's a couple specific things about this, and first of all, I love that comment, the First Nations comment as well. I love that phrase. It's really great. The balance is in making sure that the administration of the program take a look at the day, sort of a day in the life of the clinician, and find the way to structure it so that it can't be hijacked. by administrative needs. It can't be hijacked by anything. The day gets structured so that, we've all struggled with this question of what's the proper caseload number and, that type of question. But there is no such thing because every client is different. Some require higher levels of intensity and frequency. Some are lower levels and infrequent and one time. And so the number of people on a caseload is not the measure. But the amount of time a clinician spends per day face-to-face with a client, that matters when it comes to burnout. And that matters when it comes to making sure the system itself is efficient as well and seeing people quickly and reducing wait times. So I believe the answer is actually to look at numbers of sessions, numbers of hours out of a 7.5-hour day that will be spent face-to-face and structure that in the calendars. And in between those is structured time meant for the documentation that is required after you've weeded out a lot of the stuff that isn't. So that you're kind of guaranteeing that people are not going to be overrun. You're not squeezing in, 5, 6, 7 clients a day doing intensive work in a therapeutic environment. You're controlling and balancing that with the numbers. And staff have a lot of input into this. They have good opinions about this stuff, and many of those who really like to work hard and want to see the most clients and do their best work, they can be very helpful in figuring out what that number is. We ended up standardizing in a sense, and standardizing from a number perspective, not from a client service perspective, but 4 sessions a day. And 20 a week, and then building in the administrative time into the schedule so that it's not being done after work or kind of off the side of your desk, as people would say.
Thanks again. This one comes from Vanessa. If the administrative requirements don't change, but the employees are expected to be more client-centered by seeing more patients each day to reduce the wait list, my concern is that it would lead to burnout. Do you hear this concern a lot?
Absolutely. I honestly believe that. If you look in any program across any workforce, you're going to find a diversity of people in terms of really all characteristics of personality and work ethic. And so, in every group you'll find a few who will try to just do less, and that's irrelevant. But most people who are in this kind of work, they're there because they want to be seeing clients. But we know burnout is a huge risk. And so the problem, and this is why I'm really focusing this way, and I continue to repeat this, the problem is not the care providers. The problem is the system. And any system that does not structure the days of the care providers in a way that protects both the availability of appointments and the well-being of the staff, if it doesn't find that balance and then make that part rigid, then the system is actually neglecting one of the two most important, either one of those two important things in the program. And so there is a need to find that balance and enforce that. Some people will find that to be a relief to see, for instance, only 4 a day, and some will find that to be an enormous increase in what they do. So that it's all over the map, but preventing that burnout matters.
Thank you very much. I'm going to combine 2 here. The first, and then you can just hear the second. It's somewhat similar. So would a collaborative or recovery approach to mental health or addictions care reflect a movement in the best direction whereby the individual and family would drive a collaborative approach in partnership with clinicians? And so that's the first part. And the second one comes from Yvette. So I think it's kind of along the same lines as I'm wondering how much of these principles stem from the recovery approach to care.
I think there's enormous consistency between what I've written in this book and what I'm talking about, and a recovery-oriented kind of philosophy and approach. Because, and here's the key reason why I would say this, because in our traditional system, it's a pathology-oriented kind of approach that dominates the field. So, the people who typically have been in charge of the system are people who come from clinical backgrounds, and that's great, but the history of the field is one that is designed around assessing, diagnosing, and treating illness. so addiction or mental illness. So it's the focus of the entire program is on that. It's looking for pathology, and it tends to be looking for putting labels on, and it tends to be looking at experts providing treatment. And there really is very little room for family and community-based organizations to provide recovery-oriented approach and recovery-oriented supports, as opposed to treatment, as opposed to expert type of interventions. There are many people who don't need that, and in fact will do worse in those situations. And so that's why organizations that are out there, community-based organizations that provide more of that, so family service organizations, CMHA branches, there are lots of these that are more of that recovery-oriented kind of approach. And like Channel in Newfoundland, if any of you are from Newfoundland, there are lots of those that take that approach, and I think it's part of the necessary continuum. So, it's very consistent, and it needs to be part of what we do. It's not an either-or.
Okay, this one's a fairly direct question. Can you share strategies to maximize the opportunity of empty appointments we see, no-shows, less than 24-hour cancellations?
Yeah, we had a couple of methods that we had used, actually, that worked really very well. First of all, as a precursor to this, you have to have a centralized booking system. And so what I mean is that clinicians don't book their own appointments, but an intake team has access to everybody's calendars, and they're the people who are on the phone with the clients, and they're the ones providing whatever appointment is available on whatever day this person wants at whatever time, with as much choice as possible. So you kind of need to have that first, because then what happens is when somebody calls in with a cancellation, I call and I say, I can't make it to my appointment tomorrow, I'd like to rebook it. Well, you're talking to the intake person. The intake person rebooks your appointment, but that intake person now knows that there is a slot available at 2 o'clock tomorrow afternoon. And that person can now look at some of the people who are further out, who are waiting longer, who have been booked, but maybe they're booked a couple months out, and who may have more important or more urgent kinds of needs, and can call that person and say, a cancellation just came up. Do you happen to be free tomorrow at 2 o'clock? And so, and even same day, we've had people who managed to come in with an hour or two of notice, actually. And so or the other thing that can be done is that if it's short notice, then the time that is wasted, say for the clinician that has just a no-show where there's no notice at all, that clinician could use that hour to do some of the administrative work, the case notes, the paperwork, that kind of stuff that would have been done sometime during this week, and then take some other administrative time from another day later in the week and turn it into a client appointment. And so we've done both of those things, and we ended up with virtually no empty slots, virtually no loss of what the system would call productivity, but virtually no loss of client appointments due to no-shows or cancellations. But it requires that flexibility, responsiveness. The client calls and cancels, well, let's get another client in that appointment.
Thank you. This is just a comment, I think, from Brittany, and then we'll move to a question from Shirley. So Brittany says, I love the client-centered approach, but how do you work in a system that is based on business? People at the top are not social workers. They have an education in business. This does not allow for the frontline social workers to be very client-centered. So I guess there was a question in there, but I think it was more of a statement, and I'm going to move to Shirley's question that you might be able to combine the two. We are considering using evidence-based manualized programs for specific disorders, including groups as well as individual services. Clients may not be asking for that, especially groups. Does that not mean client-centered? How much control via case plan or can a client have?
Okay, yeah, those two questions are related, or those two items are related, because really all of the decisions about what kind of care the program is going to provide, whether it's manualized, standardized kinds of approaches or not, tend to be made by the people who are in the administrative positions, unless they have, say, clinical supervisors or others who get to play a significant role in those decisions too. But So the solution to the administrators with more business backgrounds, I think it's just fire them all. I'm kidding. That was a joke completely. I was one of them. So, but no, I think the solution is we need to get those administrators to start to recognize what this actually means, and that taking this approach can improve the efficiency of the program from a business perspective. So when we did this transformation that I started talking about today and that I'm going to talk about more next week and the week after, when we did this transformation, we dropped our wait times for adults from 8 months to 1 month with no new money. Now, you find an administrator who can't relate to that as worth pursuing. And the shift that has to happen is to help them to see that instead of looking for efficiency for the system, we need to start to look for efficiency for the clients. And in doing so, we will remove a ton of barriers to both at the same time, because the barriers to the client are actually things that we're doing to them, roadblocks we're putting up for them that we don't have to do. In other words, we're freeing up our own time by making it more efficient for them, by doing less things to them. So that's that part of it. And the manualized treatment part of it. So once what happens inside a clinical session, I believe needs to be evidence-based. And I come from a science background, so I tend to believe in empirical kind of evidence. However, there are various ways to look at evidence, but because it's a public sector program, it's tax dollars, the people paying them, expect us to be using methods that actually change the health status of the people who are there. And so we have to be careful about things like placebo effect and other sort of indicators of success, really, that are not really changed health outcomes. So we have to be careful because we're public sector programs, tax dollars. But having said that, we need to be able to provide flexibility as much as possible up to the point of using non-evidence-based approaches. And that flexibility, I believe, must include, if it's at all possible, it must include choices around whether you're going to be seen individually or in groups. If we create standardized group approaches and say, for anybody with this particular problem, this is what we offer, this is the group we offer, well, then we are not at all making that decision based on clients. We're making it just based on the evidence of effectiveness of an approach and not allowing for individual options. And we're going to be shutting people out. We've got a long history in the addictions field of somebody, because coming from a disease model, a 12-step model, somebody would show up at a program trying to get in, and unless they were willing to admit that they were an alcoholic, to use the old term, then they would be told they're not ready for treatment. That because we only provide this type of program. If you don't fit, you don't fit. And that's why we never served enough women in the past in addiction programs, because it was a man-oriented program. And so those kinds of things about providing choices of kinds of group or individual or types of initiatives, we have to have some flexibility there.
Thank you very much. It's a great question from Lucas, and I'm going to tag on to it. It's a two-parter for him, and then I think I'm going to tag on as well. One of my biggest challenges, he says, is getting systems to respond to issues they identify as someone else's issue. For example, meth-induced psychosis, mental health system folks want addictions response, addiction system wants a mental health to respond, etc. And what I want to tag on to that is something maybe you're touching onto in the future webinars. But we're often dealing with intersecting systems, and so if you're a client-centered, but the other systems that you're intersecting with are not, how do you manage that? And I think Lucas is kind of hitting in that same direction.
Yeah, I love that question. I love the examples, and I'm going to give a very specific answer that is, stay tuned for part 3 of this webinar. That's exactly right.
Oh, look at that. I think they call that, is it not bait? I forget what that's called in the radio industry, but you'll have to come back for the second and third to hear out.
Yeah, that's right.
All right, from Sheena, what are the good ways to evaluate or show outcomes change to health status? Recommended tools. Did I say that too quickly, or did you get it?
Try. Wait, now I'm just going to pull it up in front of me here.
What are good ways to evaluate or show outcomes change into health status, recommended tools?
I'm not sure I'm the one to ask that of. I'm not the most familiar with clinical evaluation tools at this point, so I have to pass on that
most
one.
Understood. How much information is required in a client-centered system in order that the client is informed of the risks and benefits of therapy?
Well, when the risks and benefits, the concept of informed consent is really what we're talking about in this case, and what we need to, the two things that need to happen for informed consent to happen and to be valid from an ethical and legal perspective. One is that the client is able to comprehend the risks that you're explaining, mostly the risks, more so than the benefits. And so you have to have enough information about the client to be able to understand in that first few minutes of conversation if this person is capable of comprehending. So that's about capacity to consent, really, more than anything. But then on the other hand, the client needs to understand enough information, specifically, more than anything else, as we know in this field, more than anything else, they need to understand the exceptions to confidentiality. And those are different from province to province. So making sure that they understand is what matters. And so providing somebody with a consent form that lists things and just having them sign it does not constitute informed consent, because it's clearly got nothing to do with the client. That's got to do with putting a paper on the file that has the client's signature. So there needs to be enough time spent to be able to say, if you talk about child abuse or neglect, I do have to report that. I'm required by law. It's not my choice, et cetera, et cetera. And so can you tell me what I just said? And to make sure the person understands it. But so the basics, there's a two-way exchange of information and understanding of that information that has to be in place in order for it to be valid, informed consent.
Okay, I have two questions that are fairly similar. We have about 5 minutes, a little less than 5 minutes left to go in the presentation. So if you have any burning questions, please do type them in now. I do have a number lined up, so I may not get to all of them, and I do appreciate your consideration and recognizing we can't get through them all in this time period. James says, in considering many potential solutions seem to be prevented due to administrative concerns, and many administrative decisions in the formal treatment system particularly seem to be based on fiscal and other political concerns. How can we ever expect to move toward a client-centered systems without holding leadership at senior levels accountable? The second question is along very much on the same line is given that many political leaders are talking about mental health at the higher level recently, how can we be talking to elected officials about the need for a shift towards more client-centered services?
Yeah. This still, I guess, we have to be pushing. So, the point is right. The accountability for making this happen, it lands at the top. It's not something that's within the power of any individual clinician who really wants to be able to work this way, who wants to be in a system that doesn't prevent them from doing good client-centered work. But, we have to make this concept a political issue. So here's what's happening. If you look across the country, there are advocacy groups who are, and some very large, like CMHA, and some smaller. In PEI, there's a group of 3,000 or 4,000, a Facebook group that's been launching a campaign there. We've got advocacy happening all over the place. But what's being asked for is just, we need more money, and we need more psychiatrists. And people aren't actually asking for this philosophical shift. And we need to start to advocate for this kind of shift, not just for more, because more of the same will not give us different. So we need to be more precise and make it a political issue to make the fundamental shift philosophically in the programs, not just a political issue to write a check. And that requires that we start to say this stuff out loud and talk client-centeredness. We have to be able to kind of push that because we see unethical things happening all the time. I know an organization that hired as its top person to transform the province, hired the person who had the highest wait times in that entire province into the lead position to transform the system. So, we've got accountability problems, but, we need to start to shine a light on those things. because that's simply not
Thank you very much.
client-centered.
I would like the audience to know, and we're just about to wrap up, CSW is part of the Canadian Alliance of Mental Illness, Mental Health, and we have been one of those coalition of 17 national organizations as a coalition pushing for more access and more money, but in that also looking for system transformation. And my initial question on intentional design was trying to reach out, and your answer was very much that we have to look at the local, not at the full-on system levels. But I think we need to. One of our goals is to put mental health funding on the same funding as physical health, and that's on the national level what we push for here. And I very much appreciate your time today, Todd. I'm recognizing people, it's 1 o'clock, it's a little past 1 o'clock, and people may be needing to head out or go back to work. I'll ask one or two more questions, and then we'll end it off there. And first off is a question. It's not a question, it's actually a statement again from Louise. Client is not a word I use. I use family member, etc., then call them by their name, just like I do. I want to be called by my name. And I think that is a very powerful statement in itself. And so I want to end on this last question because we haven't touched on it yet. And given this approach, given the client-centered approach, do you have any recommendations how to implement it in a new private practice?
Oh, yeah. Well, the interesting thing about private practice is that private practice will tend to end up more client-centered than public service, in my observation, because it's in the best interest of the clinician, as you know, because it's also a business. It's in the best interest of the business to actually do what the clients need and do it the way they need it. So there are less worries there. I see many private practices that I know are functioning far more client-centered from a system perspective than the public sector. So I wouldn't worry about it, except just take this same idea and don't just think about the practice as being a clinical service. Think about it also as being a process that people have to go through. And then, ask yourself the question, if this was my daughter, if this was my mother, how would I want that process to work? And I see a question there from a former student of mine. Fred, can we take that one? I didn't look at what the question is yet, but...
She's just letting you know that she took a class with you, and great to learn from you again. In smaller nonprofits, data collection is often required by funders to justify continued funding. Your suggestions are welcome in terms of responding as individuals and organizations to funders' demands and more. So it's, I think, more of a comment and a thank you. And there's a number of comments that have gone through thanking you for the presentation and stating how good it was. And please do. There's a number of people have asked here if the PowerPoint will be available. And of course, the PowerPoint will be linked as well as this presentation, a recording of this presentation, to the CSW website in the next coming days. And for those of you who attended 45 minutes or more of this presentation for your continuing education, you can download a certificate from the presentation a few hours after the conclusion of this presentation. So you can log in either later in the evening or tomorrow using the same link that you did to access the live event, and there you'll be able, on the bottom right, there should be a yellow icon on the rightmost bottom of the presentation window that you're watching now that you can click down that you have attended. And finally, in advance, thank you for taking a few minutes, if you will, to just complete a short survey to help us inform future webinars. And also would like, again, finally, to thank Todd for lending his time and his expertise to presenting today. And I'm certain the people in the audience today have signed up and will be ready for the July 26th, noon Eastern Standard Time, the next presentation in this series. Again, thank you very much, everyone. I'm sorry if I didn't get to everyone's questions. I tried to combine them as much as possible. And until next time, I thank you very much for joining the Canadian Association of Social Workers and the Nova Scotia College of Social Workers in this presentation. Thank you again, Todd.
Fred, can I just add one last thing? Just if anybody does have any questions that they really want answered, if they go to my website that's on the last slide there, they can find my email address, my phone number, whatever. Feel free to do that, to contact me if they're looking for some clarity on something.
Perfect. Thank you very much.